Hello and happy Friday. Thank you all for joining us. My name is Jody Rodney. I'm the Vice President of Marketing and Education for Plan Mecca USA. Today, this is the 10th in our Plan Mecca Digital Mastery Series. And with us is Dr. Daron Clark and Lisa Smith from Nashville, Tennessee. Our topic today is Total Practice Health, how to keep your patients and your practice healthy. Before we get started, I have a few housekeeping items. One, all attendees are muted and your camera is not on, so enjoy your PJs or yoga pants or whatever it is you may be wearing. If you're experiencing any technical difficulties, please submit your issues via the chat function. All questions for Dr. Clark and Lisa, please submit those via the Q&A feature. That'll actually help us make sure that they're all addressed in an orderly fashion. We anticipate the presentation to take approximately 50 minutes, at which time we'll then move into Q&A. Before we start the Q&A, we'll actually post the CE survey in the chat function, and I'm sure most of you know that you must complete the survey to get the CE verification. We will also send an email later today with the CE survey link in case you can't access it today, along with a recording. So be on the lookout for that email. Without further ado, I'd like to introduce Daron and Lisa.
Hello, everyone. I am Dr. Daron Clark. This is Lisa Smith here beside me. Jody, thank you for that wonderful introduction. We are really excited to be here today. I know if you're like me, I kind of need a haircut more than I need another webinar, but I think we've got some really good information for you today, especially given our current circumstances and what we're going to be facing as an industry in the coming weeks and the coming months. So today we're going to talk about total practice health. And we're going to talk about what that means, and we're going to talk about the things that you can do to achieve that. We're going to give some of our own personal experiences. We're going to share some of our strategies that we believe have positioned us really well to deal with the market that's ahead of us. And we want to show you that you can simultaneously increase the health of your patients and increase the health of your practice all at once when you get back to the office. So a little bit more introduction. Again, I'm Dr. Daron Clark. I got my DMD from the University of Mississippi in 2007. I've pretty much been a CE junkie since then, and I've been honored with the opportunity to be a KOL and a member of the Board of Education for Plan Mecca USA. I do want to highlight that my practice is a general dentistry practice. We do some sleep dentistry, we do some TMD, but for the most part, I don't think our practice is very much different than the average practice that's out there in the scope of the procedures that we provide. So I want you guys to understand that all of this is going to be very relatable to the practices that you have.
And I am Lisa Smith. I'm the Director of Strategy and Operations at our practice here in Nashville. My role kind of falls into two different categories. I am in charge of strategic planning and business development, which basically means that I help vet new technology. I manage our operations and also do all of our financial planning, our brand development, and our team development. The other side of my role is more sales and communication. I'm in charge of making sure that our patient experience is exceptional and that our team is well trained and that we're all kind of working on the same page. I also handle a lot of our new patient appointments and our consultations for different services that we provide.
So as I mentioned earlier, we want you to be able to maximize your patient's health, and we want you to be able to maximize your practice's health. And the goal is to have both, and you should know that you can achieve those things at the same time, and you can do that even in this current environment that we are all facing. So from a patient health standpoint, we want to take a view sort of from 10,000 feet here and back up from what we usually do and understand that early diagnosis is really important. because that is what allows us to have conservative intervention. And one of the things that we need to do that is have a high quality of imaging that captures a lot of data. And that's what I call responsible imaging. And you can do all that with very low radiation dosage. When we get into conservative treatment, what I'm really talking about is prepping teeth minimally, leaving as much sound tooth structure as you can, because those are going to allow you to provide longer lasting, more conservative restorations. And it's going to give you far more predictable outcomes.
And then coming at it from the perspective of the practice and making sure that your practice is healthy, it's hand in hand with the patient health, of course, and all the things that we can do better in the 4 areas that Dr. Clark talked about will also really help us to make our practice more economically viable. If you really think about it, dental practice health is actually incredibly simple. Your ability to meet your goals, however lofty they are, ultimately hinge on optimizing these 4 areas: bringing in more patients, diagnosing more, increasing your treatment acceptance, and then being able to treat your patients very efficiently. So our primary focus for today's lecture is going to be on diagnosis and treating efficiently, but I do want you to understand that when you do those things really well, bringing in more patients and increasing your treatment acceptance naturally follows. And we'll talk a little bit more about that later.
So one of the first steps of this is being able to diagnose more, and that requires improving the quality and the quantity of what you can see. And obviously, we're talking about imaging. This kind of looks like a pan, but it's not. This is what's referred to as an extraoral bite wing. You can see that the contacts are split. There's a ton of detail in this image. There's a lot that you can diagnose out of these. From a diagnostic standpoint, guys, this image is just absolutely beautiful. It shows you far more than what you're ever going to see with an FMX, with only a fraction of the radiation dosage and even a fraction of the time required to get an FMX. This is a 10-second scan in our office, and it's one of the capabilities that we have with our Plan Mecca Pro Max CBCT machine.
Oh, I wanted to jump in here also. Patients love it. They absolutely love it because they don't have to have a sensor shoved in their mouth when they take Bitewings. And with the current issues that we're having with trying to figure out how we can control aerosols in our practices, I don't remember if it was the ADA or the CDC, but I did read even earlier this morning that they're really recommending that you reduce the number of intraoral Bitewings that you take and try and take extraoral imaging, because there's less of a chance of a patient coughing or gagging or any of those things. But setting that aside, the patients really, really appreciate it, and we're able to get these images every time we take Bitewings on a patient.
So let's put our dentist eyes on, and let's dive into what we can see in this image, because I really want you guys to understand how powerful this can be. Number 2, mesial, you can see there's decay on that tooth. There's an open margin on the MO restoration on number 15. There's decay on the distal of number 18, and there's decay on the mesial of number 31. So I put this slide in to show how diagnostic these things can be. And we really need to be, and you're gonna hear this theme over and over, we need to be looking at everything and talking about everything with these patients and not getting stuck on one tooth at a time. And this slide kind of highlights the importance of having 2D and 3D capability. There's some restorations here in the extraoral Bitewing scan, but if you take a close look at number 23, you can tell there's something not quite right about that pulp chamber. And we took this Bitewing image in a recall appointment, just like we would normally take a Bitewing in a recall, but we got more information because we had this capability, and we noticed that there was something going on with number 23. So I'm not going to immediately move into a battery of pulp vitality testing to see what's going on with this tooth. I'm going to immediately take a 3D periapical image of this tooth to really get an idea of what's happening with that pulp chamber. As it turned out, when we took it, This process was happening on 23, 24, and 25. The hardware that you see in the jaw is from a motorcycle wreck that was 5 years prior to this image. So we were able to catch this, diagnose what's happening, and we were actually able to treat all 3 of these teeth with endodontic therapy, and the patient saved thousands of dollars and untold time and misery because we were able to catch this and visualize it and treat it in the way that our technology allows.
And am I right in remembering that this patient had no symptoms?
Correct.
There was no sensitivity, there was nothing going on. We would not have seen this if we hadn't been able to take these Bitewings and we're stuck with taking traditional.
Just another instance. There's a lot going on in this image, but we want to focus on number 31. Again, something doesn't look quite right about that pulp chamber. Again, I'm not going to take a lot of time and put the patient through the misery of pulp testing, pulp vitality testing in this instance, when I can immediately take a 3D image and determine whether or not this tooth is restorable. And it turns out that it wasn't. The resorption process had basically blown out the plication. And again, this was during a recall appointment. We found this problem, we identified the extent and the range of the lesion. We were able to treatment plan an extraction, a graft, and an implant all at the same time, and the patient accepted treatment, all within the time confines of a normal recall appointment. So consider making this part of what you do. These extraoral Bitewings are a huge asset. As Lisa mentioned earlier, the patients actually love it. Our hygienists and assistants love it because this saves them a ton of time, and they don't have to deal with the difficulty of taking an FMX and putting the sensor in and out of the patient's mouth all the time.
There is, as with all technology that you bring in the office, there's definitely a learning curve in making sure that you get these images to look really amazing. But we really found that it wasn't that difficult, and we had a lot of really good training to help get everybody on board pretty quickly.
So let's talk about and transition into 3D capabilities. The slide that you see here, that's a volumized airway. But the reason I put it in this image is there's about $6,000 or $7,000 worth of treatment just in this image that you're looking at. This patient has sleep apnea. That is a sleep apnea guard. Obviously, there is a periapical lesion around number 18. As it turns out, this tooth required extraction and an implant. So I wanted to really hit you hard with how powerful 3D imaging can be. And let's move into the concept of the 3D periapical image. The 2D intraoral PA that you see, the density of the cortical plate and the density of the cortical bone surrounding sinuses blocked out the lesion that you can clearly see in this 3D 5x5 periapical image that we took. And we took this at an ultra low dose, which means it's very, very minimal radiation. And here's the difference. That sensor PA that you take is 5 to 7 microsieverts of radiation dosage. The 3D ultra low dose 5x5 PA is closer to 3, but you get a 3-dimensional image that you can scroll through, that you can view at any perspective and at any focus. So the amount of radiation is less, and the amount of information that you get is exponentially more. Same thing again. This is number 3. You can see that the density and the density of the bone and the 2-dimensional scan blocked out the information that you needed to really get a good handle on what was happening to this tooth. But if we go and look at the different slices from the different perspectives in 3D, we can really see clearly and get a very good understanding of what's happening. And that is going to be a huge asset for you when you're treatment planning what to do with this tooth. And this is another instance. This was provided to me from a colleague of mine. Number 29 was the tooth in question. Number 29 was symptomatic for months. Number 29 was pulp vitality tested multiple times, but relative to that testing, it never really reached the level where endodontic therapy was justified. That was until the 3-dimensional image was taken. And you can see that there's a huge periapical lesion at the base of that root that you couldn't see in the two-dimensional PA. But if we dive, so this is another example. This is failed endodontic treatment. And if we look at it just in the 3D image, we can start asking the next questions. All right, well, why did this endodontic therapy fail? Well, maybe the fill was a little short. You can tell from the sagittal view that it might be a little bit short. And the next question might be, well, are there any other teeth involved? And you can see from at least two of the views that the mesiobuccal root of the molar is involved as well. But the ability to scroll through 200 or 400 or 600 micron slices of the image shows us what really is happening. The operator who performed the initial root canal missed a lingual canal. And obviously this is really, really powerful when it comes to diagnosing what's actually happening, understanding the true cause of the problem, and treatment planning appropriately. And I'll add that when you can solve these problems for this patient, because this patient had been in pain for quite a while with a problem that they thought they'd already paid to solve. When you can solve these problems this quickly in this way for these patients, you're going to start to inspire a lot of trust and a lot of confidence in your patient base, basically in their confidence in what you can do in your office.
We don't really, one of the best things about this is that in a lot of ways, we don't have a lot of dental mysteries that come to us that we can't figure out what's going on anymore. And we're able to treat patients who have bounced around to different providers and they couldn't figure it out. It's not the provider's fault. They just don't have the ability to see what we can see. And of course, we're always really kind when we have a patient who comes in and we let them know that their provider did everything that they could with the imaging that they had. But this differentiates us, and our patients just see by the way that we take care of them how important and how valuable that is. That creates a culture for us.
So you might be asking, how often does this happen? Well, we've got data on how often we miss things in two-dimensional radiographs. And this study showed that 25% of the time, a two-dimensional PA is going to identify that a lesion is there. And by contrast to that, if you have 3D capability, you can identify the lesion 100% of the time. So do you want to be right 25% of the time while your competitor down the street may have the capability to be right 100% of the time when it comes to these cases? And to add to that, you saw in the previous examples, you don't just get identification, you get a good understanding of the extent and the severity of the lesion that's there when you have 3D imaging. So one of the questions that's often asked is, what about radiation dosage? And the ADA a few years ago came out with a statement on this, and I'm not going to run down this rabbit hole too far. The take-home message is that the ADA wants you to not radiate the patient without a good reason, and they want you to be responsible when you do it.
And that's something that is really important. Responsible, making sure that you're not dosing your patients irresponsibly is really important. You have the ability to use this technology and use incredibly low doses in order to get the information that you need, first and foremost. But also, when you take their recommendations, you have to remember that it's very important. The structure of your appointment is very important in order to be able to get the imaging that you need for your patients. We needed that Bitewing image on that asymptomatic patient because we needed to be able to diagnose that before he started experiencing symptoms. But we can't just radiate everybody just because. But if you bring your patients back and you sit them down and you do your screenings and talk to them before you take your imaging, then there are oftentimes plenty of reasons that will very easily show that you needed to take this imaging. We take Bitewings because patients have a high caries risk, or because of a bunch of different things. We have to follow those rules very specifically. So just make sure that your appointment structure supports you being able to get this imaging and that you can back up why you took the imaging in the first place.
So one of the important concepts when we're talking about radiation dosage is the thing that we all live by every day, the ALARA concept, which is basically means just get what you need as low as low as reasonably achievable as far as radiation dosage. But 3D requires us to think a little bit differently about that. And it introduces the concept of ALADA, which is as low as diagnostically acceptable. So the take-home message here is conservative intervention requires early identification. And if we're going to identify early, we want to dose them as little as we can, and we want to get as much information as we can. So we need to be taking images that gives us a lot of information with the first image that we take, with the first dosage that we give. That way we don't have to follow up with excess dosage as time goes by. So I'm going to give you a couple of examples of what the actual dosages are relative to 2D imaging. So the image on the top is a 2D film pan. Everybody knows this is about 30 microsieverts of radiation. We get a little bit of information from this, and we've gotten really good over the years at overcoming the shortcomings of 2D imaging. But obviously, this is not as diagnostic as what we're capable of these days. And the image on the bottom, we've got more clarity, but we're still only looking at a 2D image. We got 5 less microsieverts of radiation, but we still have no notions of depth or really what's going on three-dimensionally with these teeth. And this brings us to the idea of taking a 3-dimensional scan of both arches. And we can do that at just about the same amount of radiation dosage. But look at all the information that we get that we did not get before. Again, these images, you can divide these into slices of 200 or 400 microns, and you can scroll through these images from whatever perspective at whatever focus you choose. And you're going to discover things that you never thought were there. I'll tell you just a little bit of information on how our imaging protocols changed when we brought the 3D technology in. Previously, with a new patient, we were taking an FMX, 170 microsieverts of radiation to get what in my mind is not a lot of information. And then we would take a film pan, which is another 25 to 30. Now, what we do with new patients is we take this extraoral Bitewings scan, which is 5 microsieverts of radiation. It is essentially the equivalent of taking 1 intraoral 2D image. We get way more information than we would ever get on an FMX. Diagnosis is much easier for me. It's much faster for me. And then when indicated, we take a 3-dimensional ultra low dose 9 centimeter by 16 centimeter volume, and we can do that at 24 microsieverts, and we can get a ton of information that we can manipulate and view in 3D.
And when we're talking about all of these things, we need to look at what is it going to take in order for somebody to actually have this 2D, 3D imaging capability in their office, and it's an investment. And when you're considering the investment, you also have to consider that you need to invest in the education that you need in order to be able to really use this equipment really well. Dr. Clark wouldn't be able to do all of the things that he does now, all the things that he showed you, if he hadn't spent a good bit of time learning how to best use the equipment and learning what he's looking at as well. And the more you learn, the more you'll see other ways to help get your patients healthier. Another consideration, of course, when you're looking at this is the initial investment of the equipment and the money it takes to train your team and your doctor, but also what's the demand for the services. Anytime you're thinking about bringing something in, you have to weigh everything out and think about these two things. But I would want to say that you really, don't let this limit you too much in terms of the investment. Honestly, you guys are probably, if you make a decision to bring in 3D imaging right now, you're probably going to get a better deal than even we did, just because the interest rates are so low. You might be in a position where you can take advantage of the current economic situation. And when you're considering demand for these new services, it's a little bit different when you're talking about imaging than if you're thinking, oh, I want to go get training on implants, or I want to add sleep medicine to my practice. You have to analyze how many of your patients you think really need those services so you can figure out what that return on investment is going to be. With imaging, you almost don't have to worry about that, because all of your patients are going to benefit from this. The demand is easy. Every single day, all of your hygiene patients and your new patients, you are going to immediately be able to diagnose more. And so I just want you to keep that in mind. Oddly enough, when I was looking back at our history, when we brought in the imaging that we have now, I noticed when I was going back through the numbers that we actually had a pretty significant jump in our diagnostic revenue. So this is the revenue that comes in when we take Bitewings and PANs and PAs and things like that. Comparing it to periods previously, more of our patients were actually saying yes to doing the diagnostic imaging. Our team had a much easier time getting patients to take the PAN once every 3 years and to take the Bitewings once a year like they're supposed to, because when the team started seeing all of the things we were diagnosing, it became a priority for them to have those conversations with the patients. In addition to that, from a financial perspective, from a business perspective, Dr. Clark doesn't do any endo, and I joke with him all the time that before we invested in the 2D, 3D imaging, he should have decided that he was going to start doing endo. Either that, or I should just send the bill for the machine to our endodontist, because the amount of asymptomatic pathology that we found that led to endo over the next couple of years as we went through and saw all of our hygiene patients through was around $160,000.
I get a really nice Christmas gift from my endodontist every year.
Yeah. We also noticed a big increase in our periodontal revenue. The Bitewings that you take are really, really, really great for your hygienist to be able to diagnose perio. And it also helps to have that conversation with the patient in an image that's much more easily interpreted by someone who's not a clinician. The clearer the image, the easier it is to have a conversation with the patient about it. So we definitely saw an increase in our periodontal revenue over the next year or two. And that meant that subsequently, we saw an increase in revenue from perio treatment in terms of the difference between a perio maintenance and a prophy. A much higher percentage of our practice right now has been treated for the periodontal disease that they have and are now on a more routine perio maintenance schedule. And of course, anytime you bring in a 3D imaging, you're definitely going to be able to do your implants much more efficiently. We all know that it's extremely safe, and we're able to do it in a way that is best for the patient. So that kind of gets you talking to your patients more, and that helps to improve your implant revenue as well. And I feel the same way about our TMD revenue that we had, all of which we could not have possibly done without the imaging that we brought in. So moving into treating efficiently. Obviously, you want to be doing more procedures in less time. That's the goal. And we know that when we get back into the office after this break, there's going to be a lot of pent up demand. And we also know that we don't know what the economic environment is going to look like after we get through that pent up demand. So we really want to maximize our time in the first couple of months after we get back into the office, so that we are able to make up for some of the lost revenue that we've had from being shut down, and also insulate ourselves a little bit for what is to come in the months following that. So again, very simple. Any opportunity you have to either decrease the time it takes to do a procedure is going to be really, really imperative. And the best way to do that is to invest in technology and training that is going to help specifically with these three things. If you're thinking about adding anything to your practice, you always want to look at, especially right now, is it immediately going to save me money? Is it immediately going to save me time? And does it prioritize doctor time? Is this a way that my team can have more input on the process? Can they spend more time with the patients? That includes your expanded function dental assistants, your regular dental assistants, your hygienists, everybody. We want to make sure that we're being as efficient with Dr. Clark's time as possible. And looking at treating efficiently, there's lots of different areas in everyone's practice. If we look at our practice now, there are ways that we see that we could treat more efficiently and things that we could focus on. But we need to be really vigilant about focusing on the things that are going to give us the biggest bang for our buck, right? We don't want to just start attacking everything at once or solving the problem that comes across our desk first. We want to start by making the biggest piece of the pie more efficient and more profitable. And in most practices, that's the restorative side of your practice. That's your fillings, your crowns, your onlays. So we want to take this concept of efficiency and we want to look at it again in terms of both patient health and practice health.
So from a restorative standpoint, this is what we were trained to do in school. We've all done this tons and tons and tons of times, but let's back up from this and let's look at why would we take 2 weeks and 2 appointments to put a crown on a tooth this way if we don't have to. Why wouldn't we take these 3 teeth, prepare them very conservatively this way, have CAD/CAM in our office so that we have the ability to scan and design these restorations and mill them and characterize them, and then end up with this result. From a longevity standpoint, the data shows that these minimal preps last a lot longer. Obviously, the tooth is still a lot stronger because we left so much of the pre-existing enamel there. But the other component to this, aside from the individual restorations, is doing this all at once is an incredibly efficient way to practice dentistry. This is a 2 to 2.5 hour appointment in our office. We have trained our assistants to scan, to design, to mill, to characterize the restorations, and to fire them all at once. They get very impatient with me at this point if my preps are taking too long. They want me to finish and get up and get out of their way so they can do their job. Patients obviously love it because we took what would have been 3 or 4, possibly 5 or 6 appointments, and we turned all that into 1, 2, or 2.5 hour appointment. So you can get an idea of what this is doing for your patient's time and what it's doing for your time as a doctor. But the secret to this is getting the technology, really diving in and dedicating yourself into learning how to use it. And then the final, most important part is training your team to be a part of it. Our entire team, and you'll see a little bit later in the presentation, our entire team is dialed into this. They know, my hygienists know what we're doing on restorative. This is just part of the culture of our practice, and that's what makes it so powerful. From a time and profitability standpoint, this is a comparison of what we were doing before and what we're doing now. Analog, sending off to the lab, 1.5 hour appointment for prep and impression and temporaries, a 30-minute second appointment if everything went well. And if we assume that we're getting $1,000 for a crown, we made $1,000 of revenue with all of that. As opposed to the case that I showed you just a minute ago, that's a 2.5 hour appointment. It's 2 onlays and 2 fillings. And if a crown is $1,000, if a porcelain unit is $1,000 and a filling is $200, that's $2,400 in revenue with no follow-up appointment.
And I want to add in here, when you're looking at making your schedule more efficient, making sure that you're being really productive with your time, you want to look at adding procedures that are going to take less time, make more money, but also have a really good like contribution margin. They have a good, basically a good profit margin for you. And when we went back and analyzed all of our procedures in our office, of course there are procedures like full mouth rehabilitations and huge cosmetic cases and all-on-4 cases with implants. Those are going to be big revenue with little hours, but you may not have as many of those in your practice as you do this bread and butter dentistry. So when we took that into consideration, our most valuable procedures that we do are actually our normal CAD/CAM multi-unit appointments.
So I mentioned a minute ago, our whole team is invested in this, and it's just part of the culture of what we do. So our hygienists, we've trained them to see the teeth that are in the top, the 2 images on the top left, and they have an idea of what I'm going to treatment plan when they see failing restorations, because we've trained them to do so. And what happens is they spend 50 minutes with the patient having conversations, taking pictures, talking about what's happening. So by the time I walk in to do an exam, the only thing I have to do is just not screw it up. They know what I'm going to treatment plan. I bless what they've talked about with the patient, and we go on about our day. And the question, if you don't have CAD-CAM, and this question's been around for the 20 years that CAD-CAM's been available, is how good are the margins? Well, this is one of my favorite x-rays, if there is such a thing, that we've ever taken. There is an onlay on number 12, there's an onlay on number 15, there's a full coverage crown on number 18, and there's an implant crown on number 19. All of these restorations were prepped, designed, milled, and seated in the same day in the same appointment. And look at how good these margins are, guys. And that's not because I'm an incredible dentist. It's because the technology is there and it's good enough to produce this consistently.
So some of you may already have CAD/CAM systems in your office, and that's fantastic. Once you get, if you are doing single unit crowns on them, and the way to go next would be to kind of improve your education on conservative prep design, and then work on your efficiencies with using the system. And there's lots of information out there on how to do that. Once you get over that hump and once you get through that, your CAD/CAM game will be really strong, and then you just need to figure out how to maximize your schedule and make it work. Every office is different, so you have to kind of figure out what's going to work for you. We personally use block scheduling that is based on revenue. So our patient appointments that we have blocked for that are going to be X number of dollars or higher, those are our ROC appointments, and we make sure that we fit those in the schedule properly to meet our goals, and then we fit in all of the other procedures that are either lower revenue or no revenue around them to make sure that we're scheduling really efficiently. That's something that getting back and getting going is going to be really, really important. So I want to look at what Dr. Clark's been talking about from a practice health perspective again. Ultimately, the point that I would like to make is that if you have 2D, 3D imaging and you learn to treat comprehensively with CAD/CAM, your restorative will increase. Your porcelain units specifically will increase. Ours did substantially right away. And not only did the number of units increase, but the amount that we were spending on each of our porcelain units decreased. So we saved money on each of the units that we did. In this graph, the lime green are lab porcelain units that we were doing. And then you transition into seeing that we were doing more in-office porcelain units, and then we started doing even more in-office onlays. This graph, I think, ends in like 2016. At this point, we're doing way more onlays than we are crowns. But I just want to point out that these two things are the secret sauce that will really bring in a lot of revenue for you. For those porcelain units that we saved money on, I went back and looked at what our savings were, and it ended up being around $230,000. And that's just savings from lab expenses. I didn't include in that calculation. I was trying to be real conservative because when I look back at the numbers, I was pleasantly surprised. I mean, like some of the numbers that I saw when I was looking at our practice data, it was incredible. So I try to be really conservative and not overestimate with this stuff. I didn't include temporaries. I didn't include the extra time that it takes. I didn't include any like lost production from labs having to send the cases back. I was just looking at the cost of the lab crown in comparison to the cost of a milled unit.
I want to add here, just to give, if you're not doing CAD/CAM already, just to give you some context. You guys know how much an EMAX unit costs from your lab? An EMAX block milled in a CAD/CAM system costs you about $30.
So if we think about restorative and CAD/CAM dentistry, this is kind of, from a financial perspective, this slide is kind of the most important point that I want to make. When we looked back at what happened when we brought in these two pieces of equipment and we learned how to use them really well, we had an immediate increase in revenue. Our normal growth projection leading up to that point was around 6% year over year. And so this area above the red dotted line, those blue bars, that's our actual revenue that we hit during that time. And all of that extra revenue right there is about $1 million in revenue. And that's because when you see your patients, this isn't coming from new patients that are coming in. This is coming from you treating the current patient base that you have better. You already have wonderful patients. You already have people in your practice that you see in hygiene every single day. So when you're able to see more and you're able to provide them with better dentistry in a more efficient way, it's extremely powerful when it comes to both, boosting the health of your practice. So we know that it's healthier for patients, and we also know that it's healthier for the practice, but ultimately you can't really have a conversation about these things without discussing how we get our patients to see the value and give us that well-informed and excited yes that we're looking for, especially in the current economic climate. I know that there's going to be a lot of patients who are nervous about spending money on things like dental care right now. And we have to take that into consideration when we're looking at treating efficiently and also the things that we're going to be diagnosing on our patients. And in general, the way that we get that really well-informed and excited yes is the patient needs to be able to feel it and they need to be able to see it. And by feel it, I don't mean it hurts. I mean the way that you make them feel when they're in the office. That's how you get that well-informed and excited yes. So to do that, your entire team kind of needs to rethink the way that you talk about treatment. You need to take the time to get to know your patients and find out what their goals are, and then educate them in patient-friendly terms about the options that you are presenting. You shouldn't really be a provider who is recommending treatment. You should be an advocate who is just there to help them get what they want. So what I mean by that is that they may not want to spend money on treatment, but they do want to avoid a root canal like the one that they had last year. They want to avoid being in dentures like their aunt is. They know that she can't even eat steak. When it's more personal and it's more real, and you have the time to have a conversation with a patient about those things, then it really, really helps with your conversation and trying to help them avoid having that same future outcome. You have to know your patient and know who you are talking to in order to be their advocate instead of just their doctor. And I will also say that patients don't really want to feel pressured or sold to. They don't want to feel like they're not in control of their dental health and dental expenses. When you allow them to be in an environment that fosters trust with you, between them and your clinical team, and then you also allow them to physically see what is going on that they need to treat, then that really helps you be successful. Being their advocate allows them to be in charge. They're making the decision, and it's all in a low pressure setting. So it ultimately is going to help you make your patients and your practice healthier, faster. In terms of getting into feeling it and making sure that you're creating a good environment for these conversations to happen, the key here is trust and validation. And you have to set up your practice to foster those two things. That means that you and your team really have to take ownership of your role in getting your patients to say yes. I know that we all make up excuses like the patient doesn't have the money, the patient's too scared. And that may be true. Those things I said might be true statements, but really, even though that might be true, we have a lot more control over getting our patients to say yes than we think that we do. There are different communication techniques you can use that are wonderful. And also I would say that you really need to pay attention to the environment that you're having these conversations in, since so much of communication is nonverbal. We need to pay attention to body language and position in the room, and finding a way to get some of these treatment conversations to happen in a neutral, comfortable space instead of in a dental chair where you're kind of like leaning over them, talking with a mask on. So ultimately, if you provide guidance in the right way and in the right environment, I promise you can get that well-informed and excited yes. In terms of seeing it, we already kind of talked about that a little bit. We talked about the imaging and having the ability to show our patients. Dr. Clark is a huge fan of showing the patients x-rays. I try and avoid it if at all possible. He makes a good point though, in that the imaging that we show patients, you can actually teach them to diagnose their own stuff on it because it's so crystal clear, which is wonderful. I prefer to just not have to take the time to teach them how to be a dentist. That way, I like to let them see their images this way, because it's a little bit easier context, and it really helps. When you're doing this though, I wanna make sure that you're not getting caught in the priority trap. So for example, this patient came in, let's say that this patient came in and they were having some sensitivity, and so they came in to see you to see what was going on with that tooth, because they know that they're going to need some treatment on that tooth because it's sensitive. And so you take a picture, and instead of showing them that individual picture, you show them this, because showing is always better than telling. And when they look at this, and of course patients always have a hard time kind of flipping the images in their brain and figuring out what's where. We have to kind of direct them like, oh, that's your upper right, that's your upper left. And they look at this, I bet they're probably going to point to one of the worst teeth on the other side than the one that's actually sensitive. And that starts a really good conversation about what tooth sensitivity really means, and how we shouldn't let sensitivity be our guide and allow us to prioritize treatment. Even if you start the conversation and you point directly to the tooth that they were talking about and say, this is your sensitive tooth, their immediately eyeballs are going to go over to the other side of the screen and go, what is that? Because they haven't seen this. Most providers out there aren't showing patients the photos that we show our patients. So if you show them, if you make them feel good and you let them see it themselves, it's just like with motivational interviewing, you're letting them discover on their own their problem. And then they're going to own it more, which means that they're going to be more willing to do something about it, right? So in general, the biggest thing that you can do, kind of combining all of these different things together, we know that CAD/CAM and imaging, all of these things are wonderfully helpful for practice health, but they're also really, really, really wonderful for patient health. I want to touch for just a second on how impactful they are for practice health when it comes to creating a practice that your patients are going to rave about. The culture of your practice should always support what your patients value most. And if you can pull that off, then they will refer, and tell all their friends about you and talk about you all the time about how amazing you are. And those are the kind of patients you want. You want those raving fans. So the technology that we have, the way that we communicate, and the clinical level of care that we provide, we don't even, in our practice, we don't even really walk around and show that outright. We just let it happen and let them feel it. So for example, I've heard people say that if you get a new piece of equipment, you should throw it in your office, and then every time a patient comes in, you should show them about it and tell them about it and tell your team how it's amazing and have the team tell the patient. And I think that that's fine. That might work for some people. But I think it's much more powerful if you just say, hi, here we are, we're amazing. Let's talk about you and what's going on with you. And then when you discover what's going on with them, you can show them what's happening in the 3D imaging that they didn't get the opportunity to have in the past. So it's just quietly ingrained, and it's supporting the things that the patients value most.
The analogy I like to use when we're talking about that is when you see someone score a touchdown and their celebration is just way too much, we like to score touchdowns and act like we've been there before. So
Right.
Make it part of the culture of what you do.
Right. And when you're thinking about what patients value most, the easiest way to figure that out, honestly, is to go to any practice that is has reviews that are like more than, between 4 and 5, right, out of 5. And start scrolling through those reviews. It might be yours, it might be somebody else's, doesn't matter. When you look at what patients say about people's practices, it always falls into one of 3 categories. It always talks about how the practice made them feel. It talks about the quality of the care that you provided, and that's where sometimes the technology will start to creep in. And then it talks about how you empowered them to make decisions. Now, they may not say, this office really empowered me to make great decisions, but they will say, I didn't feel pressured. I didn't feel sold to. I didn't feel like I was not in control of what was going on. They just provided me with the education I needed and the information that I needed to make a really well-informed decision. And that's the kind of review that you want. That's what you want other people to see about your practice. So I just wanted to end with this because I think that it's very important, and it's really well ingrained with all of the other things that we're talking about. When you create a practice that incorporates all of these elements and you focus on making sure that you're paying attention to what the patients value the most, you're going to be nothing but successful.
All right, thank you so much. We do have quite a few questions. Before we dig into the Q&A session, I would like to say that we will be putting the link to the CE survey in the chat function. But as a reminder, we will be emailing the CE survey link as well, in addition to the recording of the webinar. So we get a lot of questions about that. I just want to make sure everybody heard me. There will be an email with the CE survey link. All right. So I'm going to try and, some of these questions came in early, particularly when you were talking about the extraoral Bitewings. So I'll try and, whenever I can, reference when they came in. But the first question is, do you use the same codes for the extraoral Bitewings as you do for 2D films?
Okay, so ask that question one more time. Do we use the same codes for the, I just want to make sure I'm answering this correctly.
The Bitewing images that you would for 2D film?
Yes, okay. Yes, we do, because there is the ability in the software to truncate and create a Bitewing out of the image that we take. And because of that, we are able to use the same code for the Bitewings.
Great. Can you break down the protocol for imaging for a recall patient and a new patient?
Can we do that?
Yeah, go ahead.
I'll do a new patient. So when the patient comes in and they have filled out their new patient paperwork, they then come in and sit down with either me or one of my, or Lindsay in our office also does new patient appointments. And we spend some time talking to them about why they're there and what they want out of the appointment. And then we go through their health history and their dental history and all of those things. We treat TMD and we treat sleep medicine as well. So a lot of times, either in the restorative side or in the sleep or TMD section of things that we're talking about, the reasons to take the imaging come up almost every single time. And then after we have that initial conversation, Dr. Clark has a protocol that he's put in place that guides us on what imaging is appropriate to take in what circumstance with the patient. And so then we lead them to, we tell them what we're going to be doing and make sure that's okay with them. And then we go ahead and do the imaging that we need.
Specifically, what that usually lands on is an extraoral Bitewing scan, and typically it's usually a three-dimensional scan of either both the upper and lower jaw and teeth, or what we term a full volume, which is a 16:9. Because if there are risk factors for sleep apnea, if there are risk factors for TMD issues, then we need to know what those joints look like. And frankly, a 2D pan gives you very little information on what's actually happening in either of those areas.
But it is, again, very specific to each patient. And I tell our patients that too. That's a conversation that comes up. If you have really well-educated patients, if you take them back to the x-ray machine and you're dealing with a doctor who, like a medical doctor, you've lost trust. Like we have these conversations with patients all the time about how we take the x-rays and why we take them. Because it gets rid of the whole, I don't want to be radiated, because we're explaining to them in their specific situation, not just, well, we take this every year, or we take this on all of our new patients.
And we're doing that at as low of a dose as absolutely possible. For those of you who don't have 3D imaging in your office, but you know something about medical 3D imaging, the average difference in radiation dosage between medical and dental 3D imaging is, medical's about 20 to 25 times the amount of radiation dose relative to the machines that they have available to them.
Great, thank you. I'm going to make a quick comment here again for the folks who are commenting in the chat. You will receive the CE survey link in an email, but it is also posted above in the chat. We will repost it again so that you can find it easily. Again, if you have questions for Dr. Clark or Lisa, please put them in the Q&A function versus the chat. It helps us segregate the questions a little bit easier. All right, next question. This was going back to your revenue numbers that you guys were sharing. what was being shown on the 3D imaging that was not being shown on 2D that allowed for your increase in perio?
That was also a function of the better. It was not only the 3D imaging, but it was also a function of the Bitewing function, the extraoral.
Yeah.
Both.
The quick and easy answer to that is it's really easy to diagnose a 3-well perio pocket on 3-dimensional X-ray, and it is far more difficult to do that on 2D. So just one example that is an answer to that is scaling and root planing 1 to 3 teeth. I mean, that, if I remember correctly, that was a code that we had a huge jump in immediately, because there are 3-wall defects all over the place that you just don't see because of the shortcomings of 2-dimensional radiographs.
Great, thank you. So there were several questions and comments in the chat feature and in the Q&A about some of your comments about incorporating your team into the process and what role your assistant is playing. And there were several questions about, are assistants legally allowed to discuss possible treatment plans with patients prior to the doctor doing an exam?
Yeah, I hear that question a lot. That's a fantastic question. Assistants are not allowed to diagnose and treat, but assistants are allowed to have conversations with the patient about what it is that they see. So I think that we actually, as assistants and hygienists, sometimes we get a little bit caught up with that because it's really pounded, the point is really pounded home that you can't diagnose, you can't diagnose, you can't diagnose. And the semantics of that is really important from a clinical perspective, but the patient doesn't really understand that. They know that you've worked with your doctor for a long time and that you have a lot of experience and that you've seen a lot of things and that he's trained you. So as long as you're framing it and you're phrasing it properly, it is completely okay for anyone in the office to be talking about treatment with a patient. You just have to make sure that you say things like, typically when I see this in an image, Dr. Clark will recommend that we X. You're not saying you have a cavity. You're saying this looks like a cavity. Dr. Clark is going to verify that for us and make sure that's what it is. And the funny thing is with the imaging, honestly, the patients will look at it and be like, that's a cavity. And you're like, yeah, you're a dentist now. Like they diagnose themselves. But yeah, any clinicians, our treatment coordinators can do that as well. You just have to make sure that you're not, we aren't going to have a conversation. Think about it this way. As an assistant, you're not going to have a conversation with a patient with a photo and an x-ray. And then the patient's going to hop over in the doctor's chair and the doctor's going to go to town doing filling, right? That's never going to happen. The doctor has to diagnose what's going on and then we move into treatment. But you have so much power and control over that conversation with the patient, and they will feel more confident because they see how much you know. They're not going to be at all nervous by you talking clinically with them.
And to be clear, I was a little nonchalant in my description of what we do, but I do go in and I do make a diagnosis of what's happening with those teeth. It's just that we've trained our team well enough to know that they're correct in their expectation of what I'm going to diagnose about 90 to 95% of the time as well.
They also are very aware of, because you don't want to be wrong. Like you don't want to say a patient has a cavity and you have this whole conversation and then they don't. You don't want to say that you think that it looks like Dr. Clark may recommend a crown and he comes in and he says, or that you think it's a filling and then he comes in and says that it's actually a crown. There are ways to handle that in a very comfortable way that just looks like Dr. Clark really appreciates educating his team. And our team also knows if you're going to err, if you're not sure if it's going to be a filling or an onlay, just say that. If you're not sure if we think that Dr. Clark's going to diagnose an onlay versus a crown, say crown. And then when he comes in and says, actually, this is going to be an onlay, we're going to be able to save all this tooth structure, it's a positive thing for the patient and the patient's excited about it. So don't be too worried about being 100% accurate. That's his job.
He gets to carry all the risk, right?
Exactly.
So the next one is about radiation and dose. They understand that the unit for measuring the effective dose is apparently lower when using the extraoral bite wing, but how does that translate into the absorbed dose by the patient? Do you have a perspective on that?
So if you really look at it, there's a lot of conflicting information about how much radiation is being absorbed by the patient. But think of it this is a collimated beam. This is a highly controlled beam of radiation. And just think about it in the context of the pans that we've been taking in dentistry for decades that didn't really have that level of control on direction and target and scatter of radiation. I can't give you a numbers answer for that, but I can tell you that the technology with 3D imaging has just grown leaps and bounds over the last decade and a half. And I go to work every day feeling very confident that we are delivering a very, very minimal radiation dose and getting the maximum amount of information out of it. The aspect of this has gotten so wild lately. There's literature out there saying that wearing a lead vest is just allowing radiation to bounce around inside of it, which is obviously affecting the body. So hard for me to give you a really precise answer for that, but just know that the companies that provide these 3D machines, or even just 2D, the goal has been for a long time, minimize radiation, get better results, minimize radiation, get better results. And I think we're there.
Great. We actually have had a few questions about the 3D system that you're using. Can you remind everybody which system that you're using and why you chose it?
We have the Planmeca Pro Max Mid, I think is the one that we have. Again, the maximum volume that we can take is a 9 centimeter tall by 16 centimeter diameter scan. When it comes to choosing what maximum volume size you think you want to purchase, when we did this 4 or 5 years ago, my thought process was, okay, what do I want to do with it right now? But that's probably not going to be enough in a couple of years. So I'm going to buy the next size bigger volume that I can get so I can grow into it. My advice to people now when they ask me about what volume size to purchase is think about what you want to be able to do with that machine in 10 years. Because you're purchasing a piece of technology that you're very likely going to use for a bare minimum of 10 years. And you want to be able to grow into what you're using it for. If you're not doing implants, or you're not doing TMD, or you're not doing sleep right now, you may want to do that in the coming years. So you have to make that consideration. Small field
of view if you just want to dabble, but if you are thinking that you want to get into sleep medicine or TMD or anything where you have to get that bigger field of view, then if we were to do it again, we would actually buy a bigger field of view than what we have right now.
We would.
And one of the biggest reasons that we went with the Planmeca Pro Max at the time is we did our due diligence. We went and we met with the Planmeca company. We met with Sorona. We met with a couple of different companies that we looked at, and ICAT. We looked at a lot of different equipment, and we at the time had a really good feeling for the way that Planmeca's equipment kind of works together. We were also looking at the CAD CAM system around the same time. So it was in part because we liked what we saw with the culture of the company that we were getting in bed with, so to speak. But it was also because of the abilities, the history of the abilities of the company to bring in new types of technology. Like, they do a really good job of making sure that their equipment is the best out there and that they're bringing in new capabilities all the time. I didn't say that as smooth as I would like to, but that's a big part of it. And oddly enough, we weren't really paying attention to the extraoral Bitewings at all when we made that decision. But that has been the biggest thing looking back on it that has been incredibly powerful. The ability to do the extraoral Bitewings, that knowing what we know now, that would be the only decision maker for me.
Well, I get questions about technology a lot, and I think my quick, concise answer is when you're deciding to make a big technology investment in your dental practice, you have to understand that it's a totally different animal than a consumable vendor relationship. It's a totally different animal than your supplier relationship. You have to view this as if you're entering a partnership with this technology company that's probably going to last for the next 7 to 10 years, bare minimum. So you've got to approach that partnership asking different questions than what you do when you're thinking about vendors and suppliers.
And our equipment plays well with other equipment as well. It's not a closed network, so we're able to bring in other things and it works seamlessly with everything that we have. So that's really nice. I hope that answered your question.
Yes, it did. There were several of them related to that, so thank you. So the chat, I wish you guys could see all the chat comments, but everybody has been very complimentary to you and what they're hearing of your practice. And not that I think that you want the 400 people that are still left on this call to come to your practice, but there is somebody who's asking if you accept visits from other doctors or staff.
You know, we've done that. We have done that before. We're open to it. We obviously stay very busy, so we'd have to coordinate it well. But we have had we've had several doctors come in and team come in to just kind of like check out a little bit about what we do.
Yeah, maybe not for like a 3-mile radius around your office, right?
Yeah, no local people, not a lot. No Nashvillians, although I love you all very much.
I'm teasing. Okay, so interesting question. If you had purchased a different CBCT unit, would your imaging protocols be different?
Yeah.
Yes, absolutely. I don't know of another CBCT machine that allows me to do extra oral Bitewings. That is all I need that's all I need to know to make that decision given our experience with it.
And the dosage also is going to kind of make it a little bit less likely to take
the
3D.
Ultra low dose capability is really powerful. I don't know the exact numbers on a lot of the other machines, but I know that in general, the ultra low dose capability with our Plan Mecha machine is lower than pretty much everything else that I've heard about on the market outside of that.
There's so many good systems out there. It's been several years since we went and vetted them because we've had this equipment for so long. But I would really just recommend, personally, I would recommend taking a look at what the dosages are, because that will answer your question. It may make it, if you've got something that's kind of comparable, okay, but if you have something that's a higher radiation dose, it may limit your ability to take the x-ray. So you don't want to be caught in that trap. You want to make it as comfortable and easy for everybody as possible to take those films. So we would likely just be taking less images at this point, and we would be taking traditional, regular Bitewings.
And I don't think I mentioned earlier, from an ROI standpoint, the extra oral Bitewing capability is astounding. We get referrals purely because we can take those intraoral Bitewings, because people leave our office and go back to work and tell their coworkers about how easy it was.
Awesome. All right, the next question is an interesting perspective on training. So I'm transitioning to an experienced but new to me staff in a new practice location. Do you have any recommendations for training techniques or options for the doctor and staff to become efficient and competent at extraoral Bitewings related to opening contacts without actually practicing on their patients or ourselves, but looking for training and how to perfect the extraoral Bitewings?
Yeah. I think that's a great question. If you're entering into a new environment, new people, the first thing you need to do is kind of get a feel for what that team thinks of this new equipment. Like, you want to show them the capabilities of it, but also in a very kind of not intense way. Like, say, well, what do you guys really think? Get some good feedback from them about any hesitations that they might have. That was something that was actually really valuable for us to hear, because you want to give them the power to actually tell you, like, well, I'm really worried about not being able to see this, or not being able to see this, or it being difficult, or whatever it is. If you can't get your team to open up with you honestly about the concerns they have, then you can't address them. So that would be the first thing I would recommend. But also, the training that comes with the equipment is pretty phenomenal. They will show you how to take the x-rays very, very well. You will still have a learning curve once you get in to treat your patients, though, of course. there are very easy, there are sheets that you're given that show you, hey, if you happen to get an image and it looks like this is likely what's going on. And you can practice, without taking the image, you can practice looking at a patient and kind of discussing as a team, okay, with this patient, with this arch shape, how should we set the machine? What should we set the machine to? Because it's going to be a little bit different for every patient depending on kind of the shape of the arch and also the bone density of the patient. So you can practice all those things without actually taking the x-rays. But you also have to remember, once you get the patient in the machine and you take the x-ray, if you take an x-ray and you're not getting what you need, or you're getting part of what you need, but you need to change it a little bit to get the other part of what you need, if you take 2 of those, it's still way, way better than taking the Bitewings, right? Like, to get that info, it'd be like multiple PAs. So
you mean it's far less radiation than taking multiple?
Yes. If I said that wrong, I'm so sorry. But you have to make sure your team understands the radiation dosage, because they're going to be real hesitant to want to throw a patient in the machine and they haven't had enough practice, because you have to practice on patients. That's what you do. They're going to feel real worried that they're going to do it wrong. It's not that they're going to do it wrong. It's just that every scan that they take is going to be a learning opportunity for a little while. But even the bad scans look really good. So, you know.
Yeah, if you haven't, I'll dive into the details really quickly on this. If you haven't seen the extraoral bitewing function work, you really make it happen because you have control over a lot of the settings before you take the scan. You can account for different arch sizes. You can account for different arch shapes. You can account for different head sizes and bone density. So there is a learning curve where you're going to learn on the way, but the great thing about it is it's such a minimal amount of radiation. It's far less than what you were doing before. So put the training time in, put the study time in, because you've got to train and then go back, you got to learn and then go back and look at it and review it and make sure you understand it. And then you can aim small and miss small with the radiographs that you take.
If you add it up, I believe, correct me if I'm wrong, if you take one scan and you're missing something that you want to see, even if you take another scan and then you still miss something else and you take a bitewing, you're still at less radiation, like a traditional bitewing, just to see one thing that you couldn't quite get. You're still at less radiation. Make sure your team understands that.
Yeah.
And the reality is that people's teeth aren't straight all the time. And sometimes there's crowding that the extraoral bitewing function can't overcome. And if that's the case, take a single intraoral shot. Get the information, you're still getting the information you need, and you're still doing it at the lowest possible dosage.
Yeah, and I was just going to comment that, so the Plan Mecca's education department also offers like 1 hour booster one-on-one customized training for our customers. So if that's something that a practice needs, if they've got new staff, or like you said, you're transitioning to a new practice, if you want to email education@planmeccausa.com, we can get you in touch with one of our trainers to do, a webinar for you and your team, just to some of that stuff that Dr. Clark talked about. Whereas, we've got communications and pictures and stuff that will help you from a positioning perspective, but it will take that, trial and error, so to speak, to get it just right. And
I bet your team members probably haven't had bitewings in the last year, because we always end up taking care of ourselves less than we take care of our regular patients. So you'd be surprised. They might all be due for bitewings, and you can all practice on each other.
Yeah. And somebody actually just made a great comment. We actually did a webinar on Monday evening with Dr. Peter Green,
yes,
on responsible radiation, and he went into a lot of these numbers. That recording is also available on our registration site at info.planmeccausa.com/webinar. That would actually be very helpful, just to help people understand what Dr. Clark was just talking about, that even if you did have to do a retake, that the radiation is actually going to be lower. So great comment from the chat function there. All right, several more questions if you guys want to hang on here. Somebody's posted a couple times that they need clarification on the coding. How is it possible to charge out extraoral bitewings as intraoral bitewings when they are extraoral, even if you are able to split the images? There's a different CPT code for both.
Yeah, so honestly, when it comes to what you code, I try really hard not to ever give anybody any advice on that at all. You need to go and look at the codes in the book. Get Dr. I think it's Charles Blair, his book.
Charles Blair.
He has a wonderful book. If you probably already have it, but go reference in there and see which codes that you should specifically be using. Because I don't want to tell you wrong, and I don't want to tell you to do something that you may not be comfortable with. It's always our goal to make sure that we're coding exactly what we do, and that we don't veer from that in any way, shape, or form. So I would reference the code book for an answer to that. I'm sorry I couldn't be more helpful, but I certainly would rather you get the right information.
I think that's understandable. Somebody did ask if you're able to bill both Bitewings and 3D at the same appointment.
I would have a follow-up question to that, and if you're able, I know. So I'm making an assumption I'm assuming that what they're asking is if there's going to be like a write-off. A lot of times people will say, are you able to take these 2 films and still get fully compensated by the dental benefit plan? And that's going to vary plan to plan realistically, because they're going to treat it differently. But if you're doing a CBCT and you're billing for a CBCT and you're doing Bitewings, the dental plans don't really play ball with the CBCT. Sometimes medical will, but again, I would refer to somebody who has a lot more experience in how to bill medical for CBCTs for that question. If you are taking a pan and Bitewings, if you're taking an image and you're taking a pan and Bitewings, then oftentimes you do get a write-off. I think that's what they're asking, but I'm not really sure. Are you able to? Yes, because we do it all the time. Or the plan's going to pay for it? I don't know. Sometimes they don't.
Simple question. Are you using a lead shield?
Yes, we do.
All right. How many hygienists do you have scheduled at once? If we're running 4 to 5 hygiene schedules and all require extraoral Bitewings on one machine, do you just have to stagger them throughout their recall visit?
Yeah. How many hygienists did you say that example was asking about specifically?
4 to 5. 4 to 5.
Okay. So I think in Tennessee, we're only actually allowed to have 3. I think that's the most you can have practicing per doctor. And so we have 3. But we also, of course, have our assistants sometimes have to use the machine as well. We have a staggered schedule in that one of those columns is 30 minutes lower than the other 2 hygiene columns. So in general, we don't usually have 3 people all needing to take imaging at the same time. But also, we don't always take imaging right at the beginning of the appointment, right? We get the patient back and sit down and chat with them about stuff, and then get the imaging after that. So it actually, usually there's not a traffic jam for them to be able to take those images. When you get good at it, it's pretty fast, right? But if a hygienist sees that another hygienist is heading to the machine, then she'll sit there and go on to the next part of her appointment. And when she sees her leaving, she'll go ahead and get up and go do it then. 4 to 5 would be a little bit harder, but I still think it's manageable because honestly, sometimes we may not be running 4 hygienists, but we do have 4 or 5 patients who are all going into that machine for different reasons at the same time. And it really doesn't create as much of a problem as you would think that it does.
All right. Is there a diagnostic benefit to doing the highest resolution on every patient? Or does that make scatter worse?
Okay, so I have not found that there would be a diagnostic benefit to taking high-res imaging on every patient. Because you can take a scan with a very low dose of radiation, and what the computer and the software is doing is allowing you to see things very clearly with that small dose. Now, if, like in the example I showed you earlier, you're looking at failed endo and you need to really know if there's a fracture in the tooth or if there's a missed canal, then yeah, there's a huge benefit for taking a high-res image. But the great thing about it is you control the field size, which means you control the level of radiation exposure all at the same time. The second part of that, does metal make the scatter worse? Yes. Can you account for that and still get a good image that you can diagnose from by manipulating the image within the software? Absolutely.
I think they also were asking about taking high-res and how high-res versus low-res is going to impact the scatter.
The more, in my experience, from what I've seen, the more radiation you emit, the more scatter you're going to have, right? And conceptually, that makes sense. So there is sort of some nuance to learning how to manage this and what kind of what are you looking for in the first place. That gives you some guidance on what resolution you need. That gives you some guidance on the field size that you need. Taking into account what's around it, obviously, because metal makes a huge difference. You just kind of learn, you learn to get what you need at minimum dosage as you use the technology more.
And your team is going to be a big part of taking these images, and you need to make sure that you are having them take the lowest dose. I think that you would kind of find yourself in a little bit of trouble if your instructions to everybody was, okay, let's take the highest dose so we can see everything on every patient. You have to have a really solid reason to use that much radiation on a patient.
By default, unless I'm looking for something very specific and very small, our team knows to take an ultra low dose 3D image every time.
Mm-hmm.
Sorry, I was on mute. Do you recommend charging every time for the CBCT? I get a lot of pushback from my patients on this. I tell them that it will be credited to their treatment if they do the implant, for example.
I got you. That's a really creative way to do that. I think that's a great idea. So this kind of falls into two camps. Some people think that you should bill for the CBCT and charge the patients for it. You know, you want to make sure that whatever treatment you're talking about doing, some people make the argument that you want them to have some skin in the game for whatever treatment you may be talking about, whether it's an implant or whatever it is. The other camp says either, you know, bill very low amounts for it or don't charge your patient for it. We tend to fall more on that side of things because everybody worries about, well, what is the, you know, what's the cost of this PA? What's the cost of this image? What's the cost of this whatever? Those small little bits, though, are not nearly as powerful for your practice as the amount of diagnostic revenue you can get out of that for the patient. So it's very personal, but I do love that idea of saying, okay, we're going to set a fee for our CBCT, and then when you are ready to move forward with your implant, not if, is when, right? And when you're ready, this will go towards the cost of that, but that then also keeps you from taking a bunch of scans on people that aren't at a place where they're ready to move forward with it.
Compare why you would take the CBCT with the patient open bite versus closed in occlusion.
Oh, that's a good question. I love that question. I want to answer that, but I'm going to give you my answer.
You can answer if you want to.
So in our practice, we take, no, it's okay. You should.
Okay.
I'll jump in. That is such a good question.
So what's the purpose of taking your scan? Do you want to know what the joint looks like with the patient in centric occlusion? If you do, you need to take it in centric occlusion. Are you trying to diagnose something that's going on with a specific tooth? In that case, you're going to want those teeth apart because you don't want the opposing tooth intercuspating with the tooth that you're trying to diagnose on. You want that tooth to be as clean and clear as possible. So it really just depends on what you're trying to see. Most of the time, we end up taking them out with sort of the bite fork between the two teeth in the front, so that we can keep the teeth separated. Because most of the time, what we're looking for is something that's tooth-borne.
It really, but for patients who, if someone's coming in and we're going through risk factors with them, we're really big on risk factors and making sure that we're getting a lot of questions answered on the front end. So if they've got risk factors for TMD, if they've got risk factors for airway, then we're going to be more likely to take a scan with them with the teeth together, because the extraoral Bitewings that we take are going to provide Dr. Clark with enough diagnostic imaging for that area of the tooth. And realistically, the 3D image, you don't really want to be looking at diagnosing decay in the 3D image. You want to be looking at that in the 2D image more. So that would be the most, I feel like a lot of the scans that we take are actually with the teeth together, just because we treat a lot of patients with TMD.
Yeah. We didn't talk a lot about sleep dentistry today, but if you're taking an image because you want to have some idea of what's happening with the joints and what's happening, what does the airway look like, then you want to take that with the teeth together.
Gotta be.
Because as soon as those teeth move, then the jaw moves, and then all of that soft tissue in the front and sides of the throat and the tongue and everything that is attached to the jaw is going to move with those teeth.
We also do quite a bit of myofunctional therapy as well in our practice. And so we pay a lot of attention to patients' natural, like their resting tongue posture and things like that. So we wouldn't make a decision to take a CBCT to look at a patient's resting tongue posture, but if we're taking one because of other clinical reasons, and I've got somebody who we suspect has an issue with tongue posture, I'd actually rather it be teeth together, because when the patient gets in the machine and the teeth together, they're going to sit exactly like they normally do. And it helps to kind of visualize where the tongue is in relationship to everything else. So, yeah.
Great. And then I have one final question in the Q&A. If there are any questions out there remaining, please submit them via the Q&A. Somebody said, I was not clear. Did you say that dental benefit plans do not cover CBCT?
Yeah, I don't think that they do. That's my understanding. But we don't bill them to the dental benefit company, right? We're more on the line of like, I'd rather take the image when it's called for and have that and not create a barrier for it. So I'm probably not a good person to ask. Just don't take my word for it. I would say that you would really want to look into that further before, you know, for sure. I'm fairly positive though that dental plans, although there are codes for it, the dental plans do not typically reimburse. We have filed those codes in the past and we have not gotten any reimbursement back. I have talked to a lot of offices that are billing medical for those CBCTs, and that is a way that you can potentially collect on those CBCTs. You just need to be really careful and make sure that whatever fee you bill for your CBCT, you're comfortable if the plan doesn't pay, your patient's gonna have to pay. You can't, be very, very, very aware that you cannot bill your dental company, but then if they don't pay it, you write it off. You can't bill your medical company and do the same thing. So just make sure whatever fee you set, it's a fee that you're comfortable with discussing with the patient and letting them know that ultimately this is what their copay is probably going to be for that, but we'll submit it for you and cross our fingers and hope that your plan pays towards it.
Right. And then the guy who asked about the occlusion says, first of all, you guys rock. And then is looking for tips for separating the soft tissue while taking the scan, Optigate, cotton rolls, anything else that you
that's a fantastic question.
Yeah.
Because there's like, from a treatment planning standpoint, there's so much value in being able to separate the buccal mucosa from the attached gingiva, and being able to visualize where does the gum tissue stop, where does the bone start. Cotton rolls are very, very effective at doing that. I don't use an Optigate for it, but I have colleagues who use an Optigate for it. If they want separation in the anterior, it works really well. But that is a fantastic question. There is a lot of diagnostic value that come depending on what you're looking at and what you're treatment planning. There's a lot of diagnostic value in separating that cheek tissue from the attached or even some of the unattached mucosa, and understanding what those relationships and dynamics look like between the gums and the teeth and the back.
Yeah, perfect example. I want to say last week, but I mean like the last week I was actually in the office and able to practice dentistry, and I don't even know. But I very recently I had a patient who came in for a new patient appointment as a cosmetic consult, and she had some TMD issues that she didn't really realize before we talked about it might be related to her joint. She had some pain and things like that, but she was there primarily to get anterior work looked at to see what options there would be. And she really wanted to be able to make she had a very gummy smile. And so she wanted us to be able to see if we could lift the gum line and help her with some veneers. So for her, I had her in occlusion so I could get the joint in the position where it's most compressed. And then we put cotton rolls across the front so that he could have a really good visual on where the bone is, where the soft tissue is, and that made our treatment planning so much easier. And her outcome is going to be so predictable for us. So.
All right. I think that wraps up the questions. Thank you guys so much for being here. Excellent, excellent feedback from the chat. Thank you all for the questions, and for those of you that stuck with us through the Q&A. As a reminder, you will be getting an email with the link. Give my team an hour or two to get it together. We are not wizards. We can't rip it out. So thank you all. Daron and Lisa, thank you so much. Have a great weekend. Thanks to everybody for joining. Take care.
Thanks so much.